Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice case of a grade 4 IDH mutant astrocytoma. So this is a case of a 37-year-old male patient who presented with headache and was found to have a frontal mass. And as you can see here from the low power magnification, the tumor is pink in color. This is because of the predominance of gymestiocytes as the proliferating cells. So these are large cells with abundant, a large amount of acidophilic cytoplasm and eccentric nucleus. Now, you have always to pay attention that in between those large cells, there will always be smaller malignant cells that are dispersed in between the larger gymestiocytic components. So on high power magnification, these are the malignant gymestiocytes with abundant acidophilic cytoplasm, eccentric nucleus, frequently containing prominent nucleolus, and then a lot of mitotic figures. There is one here, one here. Mostly these are seen in the smaller cell component in between the gymestiocytes rather than the gymestiocytes themselves. And then here another high power magnification with the cells with abundant glassy acidophilic cytoplasm and some accentuation of the cytoplasm here near the cell membrane. And then we have this perivascular lymphocytic infiltration that is typically seen with gymestiocytic tumors, gymestiocytic astrocytoma. And now into the immunohistochemistry, the GFAP is strongly positive in the gymestiocytes, really beautifully highlighting the gymestiocytes. First of all, it shows the eccentric nucleus and then the homogeneous cytoplasm. But what is really important with GFAP is the accentuation of the cytoplasm just beneath the cell membrane, which is typical of the gymestiocytes and can really be of help to differentiate it from mini gymestiocytes, for example, or from other types of tumor cells that might stain with the GFAP. So again, beautifully, there is the eccentric nucleus with a prominent nucleolus, and then there is this accentuation of the staining at the edges of the gymestiocyte. What is really also beautiful, as I always mention with GFAP, it highlights the microvascular proliferation, the essential criteria, one of the essential criteria to grade the tumor as a grade 4, because with mitosis, the tumor would be a grade 3. The presence of microvascular proliferation, glomeruloid type microvascular proliferation, as is highlighted here, and or necrosis would upgrade the tumor into grade 4. So this is because of the presence of this microvascular proliferation equivalent to a grade 4. And then we have OLEG2, and OLEG2 is positive mostly in the smaller cell component rather than the gymestiocytes. Now IDH-1 is positive, showing intense cytoplasmic staining as well as to a lesser degree nuclear staining in the presence of negative vessels, negative internal control. It's very important to remember. And then the ATRX is beautifully lost or a mutant. We have the internal positive control, which are the endothelial cells, and then we have those the gymestiocytes showing complete loss of a nuclear stain, which would support the notion that this is diffuse glioma. So always remember, for ATRX, you have to interpret it in the presence of internal positive control, usually the endothelial cells, sometimes, for example, the lymphocytes, sometimes we can use the neurons as the internal positive control, but you cannot really interpret a negative nuclear stain without the presence of internal positive control. And then p53 beautifully is strongly positive in 50% or more of the tumor cells consistent with abnormal expression or a mutant expression, again in the presence of the normal staining pattern, which is the mosaic staining pattern in the tumor cells. And then finally, the Ki-67 highlighted the increased proliferative activity estimated around 20%. So put together the diagnosis as per the new WHO, the 2021 WHO classification of central nervous system tumors. This is considered to be astrocytoma, IDH-1, and this is the way we write it, P, meaning protein, R132H. This is where the mutation occurred, the mutant. Then CNS WHO grade 4. Remember that with IDH mutant gliomas, we no longer use glioblastoma. So we cannot use glioblastoma anymore once we have a grade 4 tumor that is IDH mutant. And this is because of the associated better survival and outcome in this group of patients in comparison to the wild type, IDH wild type, glioblastoma, for which the glioblastoma has been reserved. Previously we used to call it glioblastomas or grade 4 CNS tumors showing p53 mutation. Secondary glioblastoma again no longer is in use. This is exactly what the WHO requests us to, or recommends us to write, the integrated diagnosis. So remember, with IDH mutant gliomas, high-grade gliomas, we only use astrocytoma. We no longer use neither gymnastiocytic nor secondary glioblastoma. And remember that this tumor is graded as grade 4 and treated as a glioblastoma, but the terminology is important to separate it from the much worse outcome on patients with IDH wild type molecular signature. I hope you find this tip useful in your daily practice. Thank you.